So good afternoon, ladies and gentlemen. I always say that this after the lunch, it is the most difficult time of the day, so welcome. It is great that we are so many here. We are really very many people here, but still it looks like an empty theater, does it? But it doesn't matter. I think everything is functioning here, so I would like to warmly welcome you here with us. And to spare our time, I would like to introduce our first speaker, Dr. Rasa Mikelyte, who is a research fellow at the Center for Health Services Studies at the University of Kent, United Kingdom, and a part-time dementia care worker. So welcome.
Edison is presenting with me.
And yes, and Rasa, if I may ask you to introduce your colleague who is presenting with you, it will be very easier for me. Okay, thank you for your kind help. Yes, thank you. And if you don't mind, I will be sitting there to see you better.
Hi, everyone. Thank you for joining us after lunch. As has been said already, we know it's a tricky session when your bodies digest. So, hi, I'm Rasa, I'm from the UK, and
I'm Edison from Brazil.
And we'd like to talk to you today, if we stand close enough to the mic, about the meaning of a good death among people living with dementia in the UK and in Brazil, and what our findings can tell us about delivering culturally meaningful approaches in palliative care. So, today you're getting a buy one, get one free with us, but we're part of a larger, really fabulous research team. And I guess the first question is why? Why do this? So who gets to define what a good death is? It's certainly in the recent past tended to be clinicians who decide what good death is for palliative care delivery. However, with conditions such as cancer in the UK, where people living with a terminal illness are asked, what is good death for you? What would it look like? That's when how care is delivered can change in really profound and really positive ways. The voice of people living with dementia isn't heard as much in this. Limited attempts have been made to talk to people living with dementia. There's a lot of reticence, be it from researchers, ethics panels, clinicians, to talk about what death means, what good death is. And even where those attempts have happened, they tend to happen in high-income countries. And I hope it won't take too much persuading, because we certainly haven't got the time, that the way palliative care is delivered across the world is not the same. People's views, people's cultural contexts are not the same. So it's really important to not just ask those questions in one area of the affluent world and assume that it is ubiquitous or it would translate elsewhere. And if you don't believe us, believe the World Alzheimer Report that has said kind of the same thing. Please talk to people living with dementia about what good death is and what good palliative care services are.
So our aim here was to compare the views of people living with dementia in Brazil and the UK on those issues. And when we set out to develop this study, there wasn't much literature about how to conduct cross-cultural qualitative comparisons in interview studies. So we had to develop our own framework for this research. Our first step was to define common questions that were relevant for both sides and with a strong rationale into why a cross-cultural comparison would be relevant. Our second step involved designing common research questions and a common harmonized interview guides for the interviews in both countries. Then we moved on into defining pragmatic recruitment strategies for each country, because the reality in both countries are different. And our next steps 4 and 5, they were performed independently in the two countries, because we felt that it was very important for the teams making the interviews, conducting the initial coding, and performing the initial inductive thematic analysis to be matched for there to be a match between the cultural backgrounds of participants and the researchers. Once that independent phase was ended and we had separate thematic analysis for both countries, both teams sat together and compared their findings and built a common thematic framework encompassing the data from both data sets. With that in mind, we moved to the next step, which was iteratively done with the step 8, which was about comparing the themes, the common themes, but also exploring the different relationships between themes. And as a final step, we reflected on the things that we learned that were facilitated by these cross-cultural methods, and that would be harder to achieve if we had just conducted 2 separate studies. From an ethical perspective, it's important to highlight that we used the standardized protocol to assess the participants' ability to consent and to participate in the interview, which was very important.
Thank you, Edison. So we ended up with 32 participants in total, 16 in Brazil and 16 in the UK. Our interviews were carried out between August 2019 and August 2021. And you may recall something pretty important happened around 2020. So we also did around half of our data collection in person and then switched to online data collection for the interviews once COVID had started. You will see that our samples or our participant pool are substantially different in the 2 countries. We never intended to match. This is a qualitative study, so we weren't looking for samples that are comparable to each other. Instead, we looked for as much diversity and variability as possible and sampled iteratively. And just to mention a couple of things, you can see that participants in the UK were younger than Brazilian counterparts and have lived with their diagnosis for longer. So on to the really juicy stuff on what we found. We had 3 themes that were developed in our cross-cultural work. And the first one was choice and control. Now, in the UK, really all roads led to choice and control. If you asked me from the independent analysis, define what good death is for people living with dementia in the UK, I would have said it's all about a sense of control and ability to exercise choice. And then we came together, and it was completely absent in Brazilian narratives. And it's not just that in Brazil, people didn't think about choice and control much. Because as Edison said, we had equivalent interview schedules. So our interviewers prompted participants in Brazil about what would control look like for you? What choices would you like to make as you near the end of your life? And people felt discomforted to a point. As you can see in quotes on the slides, there was reluctance to talk about choice, not just that choice didn't matter. And that really struck me. One of the other things, or perhaps the best illustration of this, is around euthanasia, which is illegal both in the UK and in Brazil. Because of that, not a single question we asked focused on euthanasia. We as interviewers never used the word or approached the topic of assisted dying in any form. And yet over half of the UK sample spoke to us about euthanasia as one form of feeling in control of their lives and their deaths. Not a single person in Brazil mentioned this. So there were clear cultural differences there.
Thanks, Rasa. And so although the majority of people in both samples had some form of religious affiliation, spirituality was also a very different theme in the UK and in Brazil. So just as choice and control was the central theme in the UK, spirituality was the overarching theme in Brazil, to the extent that everything about a good death revolved around spirituality and religiosity. And some participants even spoke of it about, so a good death is all about being on good terms, on a good relationship with God. In sharp contrast with that, For UK participants, spirituality surfaced much less often. And when it surfaced, it was either restricted to the afterlife, so not something that would change the way that people deal with their diagnosis now or when they are dying, or as a source of concern about the possibility that the religiosity and spirituality of others would influence their chances of having their wishes respected at the end of life. For the fears and wishes, which was our third and last theme, there was a much greater degree of overlap. So other studies had already shown that people fear dying in pain or a prolonged death process, and that was already expected. But we found something very new, and which shouldn't be unexpected, but was new, is that to a large extent, participants' preferences and fears about their own death were framed by previous experiences with the death of others. And we are simply not used to ask about those experiences. And by not making those questions, we lose the opportunity to help and to guide care. Another thing that was common in both countries was this tension between people's own wishes towards their deaths and their wish to protect their loved ones. And sometimes, and quite often, people in both countries were willing to forego their wishes to protect their families, which is also quite important because oftentimes people just speak about autonomy and disregard the autonomy of patients to protect their own families. And another issue that struck us as very relevant was that only in the UK and not in Brazil, two specific fears arose. First, the fear of losing oneself. That was quite common in the UK, but not present at all in Brazil. And the other thing was the fear of being let down by the healthcare system, health and social care system, which was also only present in the UK.
Thank you, Edison. I really want to leave time for the conclusions and discussion, so I'll summarize this as much as I can. What we looked at too is relationships between our themes. And we've hinted at this already, but what we saw is that in terms of this bidirectional relationship between fears and wishes and other themes, so what assuages fear and what may be a source of fear, choice and control interacted with fears and wishes in the same way that spirituality did in Brazil. So although all these things were present in our transcripts, how those themes interacted with one another told us about different patterns in which delivering effective palliative care may work differently in different cultural settings. The biggest no-brainer out there for sure, but the implications, I would say, are fairly wide-reaching. So what we hopefully have shown you is that this kind of way of comparing cultural or country-based perspectives is one way to expand awareness and sensitivity in which culturally informed palliative care can be delivered. So in the UK, for example, or let's say we agree across the world that planning for end of life is a good thing. I know it's a contested thing, so I won't enter the debate now, but if we say that that's a desired outcome, in the UK, offering choice, consulting people about their wishes would be enough. We were surprised by how many people wanted to talk to us and tell us about what they wanted for the end of their life with dementia. In Brazil, that wouldn't necessarily work. Choice in itself isn't desired. It's just bringing more options or allowing people to express choice isn't going to get you there for care planning. But talking about supporting families or reducing strain on families later on if you make decisions now, that may support care planning.
So another implication is this idea that we can and should ask people with dementia about previous experiences with the death of others, because this may enable different care strategies. Another point is that our results raise a note of caution against global quality indices of death that are often developed without taking cultural differences into account.
We haven't got time for strengths and limitations, so thank you very much. We are open for questions, and if we don't have time for all your questions now, we're here. Please email us, talk to us, grab us there when we're getting a cup of coffee. Thank you for listening.
Thank you very much, Rasa, and Edison, for your perspectives. Rasa, from your point of view of the United Kingdom and research, and Edison from your country, from Brazil, also from the perspective of a care worker and a geriatrician, as you are by your background. Are there any questions? We have not much time, but still, I think short questions. And I don't see. Yes, please.
No, what a wonderful study, and I wish there were more of these cross-cultural studies, because this is so informative about how to offer actual, real support for end of life based on a person's life that preceded it and the culture they're in. So in terms of the people that you interviewed, did you also interact with the families and get any surveying or measurements from them? Or was it just interacting with the people who are at end of life?
So yes and no. Yes, we interacted with families, of course, while we were holding the interviews, including the online ones, but we made a very conscious choice. We don't for a moment suggest that family or friend carers' perspectives don't matter. Of course they do. But sometimes when you do research with multiple stakeholders, the voices of people living with dementia get drowned out. So we very intentionally wanted to focus on that. And in some of my interviews, for example, the carer, so often spouse or partner, were there in the room. But we talked before the interview started of, we're here, we're gonna chat all together, but I'm very interested in your loved one's perspective. And I'll still, talk to you too, but that won't be for the interview data. So I hope that answers your question.
I also would like to add an interesting note that a few of the family members who were present during the interviews, later on, they came to us to give us feedback and to thank us for the opportunity of being there, because it was very important for them to be able to listen to those things from their family members.
Thank you.
Thank you very much. Thank you very much, and I would like to invite our next speaker, thank you, who is Annika Tetrault from Finland, who will be speaking about the views of dementia care professionals on advanced care planning, challenges and prerequisites. And Annika is a registered nurse, specialized in palliative care, Master of Health Sciences, PhD student at Åbo Academy, University in Finland, and she's also full-time dementia care nurse manager. So the floor is yours, welcome.
So thank you for the introduction and the opportunity to present today. I will present a study exploring the view of dementia care professionals on advanced care planning. I will start with a brief overview of advanced care planning, ACP. ACP is not a new concept, it's something that's been around for decades. It has evolved over the years from documents such as living wills, advanced directives, and lasting power of attorney. In 2017, a large multidisciplinary Delphi panel of ACP experts reached a consensus on a definition of ACP. The brief definition is as follows. ACP enables individuals to define goals and preferences for future medical treatment and care, to discuss these goals and preferences with family and healthcare providers, and to record and review these preferences if appropriate. This definition describes a broader and more complex relational communication. ACP is a means of extending patient autonomy to a phase of life where patients are no longer capable of making their own care decisions. It gives patients and their family members the possibility to consider the kind of care and medical procedures that are acceptable or not acceptable in the future. ACP supports decision-making by informing, empowering, and enabling people. Due to the nature of dementia illnesses, there are certain challenges for ACP in the care of people with dementia. Among those challenges are timing, as the person living with dementia will gradually lose cognitive and functional abilities, balancing the need for independence and autonomy with decision-making capacity, the illness trajectory, with an average life expectancy being around 8 to 10 years in Alzheimer's disease, and some people with dementia living for much longer than that. The lack of illness insight, where the person with dementia might be unaware of their impairment and resists care, and the lack of care continuity. At least in Finland, the responsibility for care gets transferred as the illness progresses and more help is needed. And lastly, the dementia has not traditionally been seen as a terminal or life-limiting syndrome, even by healthcare professionals. The study I'm presenting is part of a PhD project with the aim to develop a model for relationship-centered ACP process in early-stage dementia care. And the objective of the study presented, which is sub-study number 3, is to investigate the views of dementia nurses and geriatricians on ACP in dementia care. This slide provides an overview of the thesis. The first sub-study was a scoping review on ACP interventions for people in early-stage dementia. And sub-study 2, a qualitative interview study where people with dementia and their family caregivers were interviewed. And the PhD thesis will be finished in a few months, hopefully. Short note about the context, study context. Finland is my home country and the setting for sub-studies 2 and 3. Finland is a developed country with established home nursing and long-term care infrastructure. The Nordic model is characterized by strong institutionalized care for older people. And it's a society with a government-financed healthcare and social care system. In this kind of society, the population lives with the beliefs, hopes, and expectations that society will take care of the ill and older people, and that family members and relatives will not be expected to provide and finance long-term care. The Finnish dementia care structure provides a wide range of services which are available to all. The investigation and path to a dementia diagnosis are conducted according to national guidelines that were first published in 2005 and have since been updated. However, ACP is not conducted in a systematic manner in Finland. Concepts related to ACP, such as advanced directives, advanced decisions to refuse treatment, and lasting power of attorney, have all been in use for a long time. However, ACP has not received attention in Finland until fairly recently, and thus there are few relevant studies. The study design is a qualitative study using semi-structured focus group interviews with dementia care professionals in a region in Western Finland. An invitation to participate in the study was sent to a total of 29 dementia care professionals. The recruitment was purposeful. In the end, 17 dementia care professionals participated in the study. Their work experience in dementia care ranged from 1.5 years to 20 plus years, and 9 of them had continued education in dementia care. And the data was analyzed according to the qualitative analysis guide of Leuven. In order to open up the focus group interviews and have a semi-structure to the sessions, the following introductory questions were used. In what phase of dementia illness should ACP be initiated? Whose responsibility is it to initiate ACP in dementia care? What are the ethical aspects in conducting ACP, as well as in refraining from doing so? And how could ACP be organized to be beneficial for the person living with dementia and his or her family caregiver? In the analysis, themes related to the person with dementia, to the care process, and to the care professional were identified. The participating dementia nurses and geriatricians expressed a generally positive view of ACP in dementia care, but at the same time held a number of views about favorable and unfavorable factors which affect the conditions for conducting ACP. The unfavorable factors are the nature of the illness and the associated stigma, unclarity in the suggested care path, with inadequate guidelines for ACP, and the demands placed on dementia nurses and geriatricians, as well as insufficient resources. The favorable factors concern creating a trusting and care relationship, getting to know the person with dementia and their family, using intuition and sensitivity in the timing of the ACP conversation, as well as receiving support in the form of coaching and time to reflect with coworkers. So in conclusion, the ACP process has the potential to be rewarding for care professionals, for the person with dementia, and for their family caregiver, and it's something that needs further study in the Finnish context. So.
Thank you very much for your presentation. The floor is open now for your questions. Are there any questions, please? Yes. I will go to you with this microphone, or yeah, if you may, because... Yeah. Just before you get the microphone, there is another section on palliative care where Jenny van den Steen will be presenting also her paper and her initiative on advanced care planning. So sorry, maybe these two sections should have been together, but it is not possible to anticipate when preparing the program. So that's it. So please, the floor is yours.
Hi there, I'm Ruth McCabe and I'm from Scotland. I wondered about the legal status of advanced care plans in Finland. Are they legal status? So are clinicians required to apply them exactly as they're written? Because I know in Scotland there's a bit of dubiety about the legality and whether they are followed always, and I wondered if that was the same situation.
Well, like I said before, we have a long tradition of living wills and also how to, like a legal representative, like your relatives representing you. We have a long tradition of that. And as far as palliative care decision, it has to be made by a physician here in Finland. So, but as far as dementia care professionals supporting a person with dementia to fill out a living will or talking about this with their family members, I don't really recall that we have like a law about those kinds of things.
So like in Scotland, it's good practice. It's seen to be good practice to follow the wishes, but it's not actually enshrined in law. Yeah. So same with us, yeah. Thank you.
Thank you very much. Important question, important answer. It's much about exchange of experience and opinion. Thank you very much for your presentation.
Thank you.
And, yeah. And our next speaker is Jesutofunmi Aworinde, who is a PhD training fellow at Cicely Saunders Institute, King's College London. The title of his presentation is An Intervention to Enhance Shared Decision-Making, Co-Design with Principal Living with Dementia at Home Family and Care and Practitioners. The floor is yours. Welcome.
Thank you for the introduction. Yeah, as has been said, my name is Jesutofunmi, so I'll be talking to you about a recent work that we've been doing, so co-designing an intervention for shared decision-making for people living with dementia, the family carers, and health and social care professionals. So I'll just start by quickly defining what I mean by shared decision-making. And as you would expect, it's about making decisions together, but for that to happen, there needs to be an information exchange between patients and professionals. There needs to be a discussion about, what is important to them, and the intention of that, obviously, is to be able to understand what individuals' priorities and preferences are, so that when making those final decisions about care and treatment, that they align with individuals' values and their preferences and their priorities. So what is the problem then? In dementia care, what often happens is that individuals actually are not involved in making decisions about their care and treatment, which obviously, as you would expect, has an impact on the care that is provided, aligning with individuals' priorities and their preferences. And so the question then becomes, how can we actively involve people living with dementia and the family carers in care and treatment decisions? So one of the ways that we know from the evidence from other conditions such as cancer that we know or signals some sort of evidence as to being able to support communication and shared decision-making is that person-centered outcome measures can actually support this process. But what we don't know is how person-centered outcome measures can support shared decision-making or communication for people living with dementia, and we don't understand what are the requirements to using it, or what are the values that people living with dementia would say about this. And so just to quickly say a bit about how person-centered outcome measures work, but before that, actually it's quite important to define what I mean by person-centered outcome measures. So I'm referring to patient-reported or proxy-reported outcome measures. So these are measures that individuals themselves can complete or have it completed on their behalf if they're not able to complete it themselves. So as I've said, we know that they can support communication in the sense that they provide professionals and people living with dementia or patients in general with an ability to be able to communicate sort of on the same level. So they have a shared language. They have something that helps them to communicate. So person-centered outcome measures can support that process of shared decision-making. But what we also know from research is that person-centered outcome measures themselves don't lead to the final decisions that is being made, but supports the process of shared decision-making. So this is what we wanted to understand in the first piece of work that we did, looking at how we can use person-centered outcome measures to enhance shared decision-making. And I'll just point your attention to the box in blue, which shows person-centered outcome measures as an intervention, and what the components of it are, and how they lead to supporting shared decision-making. And as you can see in the third box, one of the main things is that they support knowing the person, so understanding the person, understanding what their symptoms are, what their concerns are. And if you want to read more about this, you can scan the QR code. But the other thing that I want to draw your attention to on this slide is the red text. So although we do have now some knowledge of person-centered outcome measure and how they can support. Yeah. Sure. Yep. So we now have some understanding of how person-centered outcome measures can support shared decision-making. What we don't, there are still some gaps, and those are the text that you can see in red. So there's still some gap in knowledge and our understanding of how person-centered outcome measures can work, particularly for people who are living with dementia at home. So with the knowledge that we have, and with the gap in knowledge as well that we have, we wanted to co-design an intervention that could enhance shared decision-making for people living with dementia at home. So this is incorporated within a bigger project called Empowering Better End-of-Life Dementia Care. And actually, this larger project has an intervention that's been designed within it, which comprises of a holistic assessment or person-centered outcome measure, as well as decision support tools. And I'll quickly explain what the intervention is. So the intervention, like I've just said, comprises of two main things, but we have it in a paper format and we have it as an app. So I'm just showing you the app format here. So the holistic assessment or the person-centered outcome measure is called the Integrative Palliative Outcome Skills for Dementia. And the intention of this is to help to identify patients' symptoms and their concerns in the past week. There are 3 versions of this. So there's a staff version, a family care version, and a person living with dementia version as well. I mentioned earlier that person-centered outcome measures alone do not lead to those final decisions that is being made, but they can support the process of shared decision-making. So as part of this intervention, there's something also called decision support tools. So the intention of the decision support tools, after you've identified the symptoms and concerns of individuals, the decision support tool helps you to think about how you might assess an individual's symptoms a bit further, to think about what are the causes, and then to think about how you might treat them. And then finally, part of that as well is something called priorities of care list. So that is to help to record what are the main priorities of an individual or the family carers, and then to record how they will be addressed. So this intervention as it is what we wanted to explore and wanted to understand how we could use this to enhance shared decision making. So we took what we knew into our co-design workshops. We held 5 co-design workshops, and in 2 parts really. So the first part of it was to develop the intervention for shared decision making, to understand how it could work, what are the processes, and what are the requirements, and what are the benefits. And then the second part of it was testing and refining the intervention. And there are some pictures of some of the workshops that we held. So in between each of the workshops that we did did rapid analysis to understand what are the main things that were coming out of the workshops. And then after the workshops were completed, we undertook reflexive thematic analysis. And I'll just present to you some of the findings that we had. So we generated 3 themes around how we could use the intervention that I described, how we could use it to enhance shared decision making. So the first part of it was about knowing the person and personalizing their care. The second was engage with and consider all perspective, and the third was training and support. So the first part of it, knowing the person and personalizing their care. So this was really taking into consideration the person-centered outcome measure, which I described as helping to understand an individual better in terms of what their symptoms are, what their concerns are, what their problems are, and really it was just helping to build a picture of an individual. But what was very important within this was actually to be involving people living with dementia in this themselves, involving the family carers in this as well, to help to understand, what actually is there, what are their concerns, and considering their perspectives in this. The other major thing that came out from this theme was around culture and religious beliefs, and how that might actually have an impact on whether people want to be involved in making decisions. But the main thing here is that it's important to be involving the person and asking them whether they want to be involved, but also considering their religious backgrounds and their cultural backgrounds, as that might have an impact. The second part was engage with and consider all perspectives. And really, this is just pointing to the fact that in shared decision making, that when an individual with dementia when they're able to be involved, and the family carers are involved as well, there might be different priorities and preferences that are reported. And so what's important here is to actually not to ignore the person living with dementia, but also not to ignore the family carer, but to consider both of their perspectives, to explore further why it is that they have the different priorities and preferences that they're reporting. And the role of the health and social care professional during this process is to guide the conversation to try and understand those priorities and preferences, and to be making those final decisions together. And then the final theme, training and support activities, as you would expect with any form of intervention, is that obviously, people need to be well trained and knowledgeable about what it is that they're using. So one of the major things about how we can train or support individuals living with dementia and family carers is to have instructional animated videos which provide information in small chunks, so that they're able to really understand the different aspects of the intervention and how it's supposed to be used to support shared decision making. And then face-to-face training, and as well as promoting what the benefits of using this intervention in this way, in a way that could enhance shared decision making, promoting the benefits of it or the anticipated benefits of it, also was important to encourage individuals. And I just want to share with you some of the things that came out from the from the workshop around what people were reporting as some of the values of using this intervention to enhance shared decision making. So the first one, from a family carer's point of view, they said, yes, I think one of the advantages of having a tool like this, so referring to the intervention, and for family carers is to be able to understand all the different parts of it and how it works. It gives them strength to argue their case more. And from a practitioner's point of view, you learn so much about your clients, but also so much about yourself if you're up for it and you don't just want to do a job. You actually want to be on a journey. So that just reflects very nicely that this intervention actually has a lot of potential to, not only for family carers and health and social care professionals, but also for health and social care professionals as well. So then just to wrap up, I've presented to you a newly co-developed intervention, which we've developed it in a way that can enhance shared decision making by building up a picture of an individual in terms of what their symptoms are, what their concerns are, and hopefully stressing the importance of making those final decisions together. I've also talked about training and support and how that's important to be able to use this intervention. So we've put things in place to be able to use this intervention in a way that it's intended to be used. And just thinking forward about what the next steps are. So the next steps, hopefully within the next month or so, is to be testing this intervention that we developed for shared decision making, to be testing it in clinical practice, so in 2 NHS sites in the UK. So testing it to understand whether it's feasible, and then to understand what are the processes of how it's actually working to reach those goals of shared decision making. And finally, I just want to acknowledge and thank everyone who was involved in this study and making this study possible. Thank you.
Thank you very much for the presentation of this very useful project. And are there any questions, please? Would you like to comment or add something or ask our speaker?
Yes.
Yes, please. If you kindly may introduce yourself.
My name's Phyllis. I'm from Canada, and I guess my question for you is, what was the mean age of your individuals that were involved in this as people living with dementia?
It's a good question. I can't remember off the top of my head, but I think it was around sort of the 80 mark. Older. Yeah, we didn't have very many people living with dementia who were sort of younger or younger onset dementia. We had a few, but most of the people who were involved were older.
Okay, thank you.
Thank you. Thank you for your clear question and answer. I do not see any raised hand, but it's fine because we are pretty on time and we will have maybe some few more minutes in the end of our session. So thank you once more for your presentation. And our next speaker is Charlèss Dupont from the Netherlands, who works in Belgium. She is a nurse with her background in communication. Charlie works now for the end-of-life care research. She is also a PhD student, and she will speak about a novel interactive advanced care planning website for people with dementia and their family caregivers. And she will present the results of an evaluation study. So the floor is yours. Welcome.
Thank you so much. So I'm Charlèss Dupont, and together with Professor Lieve van den Blok and Professor Tine Smets from the End-of-Life Care Research Group in Belgium, we have developed and evaluated a website for people with dementia and their families to support them in advanced care planning. So when dementia progresses, there are many challenges, and among these challenges is also the shift in decision-making responsibility. So in the early stages of dementia, people with dementia can actively participate in choices about their future healthcare and possibilities for treatment. But when the disease advances and cognitive abilities decline, there's often a transfer in the decision-making responsibility towards family members. So this transition, among some other things, underscores the significance of advanced care planning. And advanced care planning, or sometimes short ACP, is a process that enables individuals to make plans for their future care and treatment, and to do that together in discussion with families and healthcare professionals. So in dementia, we see that people like to discuss some topics of advanced care planning also within the family context, so together with family and friends in their own homes. And this approach fits within the public health approach of advanced care planning, in which we try to normalize and conversations about death and dying, and to discuss topics related to ACP. For example, social aspects, first together at home and after with the health professional. And we see in other populations, for example, patients with cancer, that the use of ICT or technology can be very useful to help people with these aspects of ACP in the family context. So what we did, we started from scratch full development of a technology, and we chose to use a website to support people with dementia and their families in advanced care planning in the family context. So our development started off with several studies. So we looked, for example, best practices, what tools were already out there, how did they approach advanced care planning, which functionalities they used. But we also discussed with family members of people with dementia and health professionals, if we develop such a technology, what should be in that website? How should we approach ACP? What kind of functionalities should we have to be able to have an inclusive and accessible piece of technology, actually. And we also looked at all the websites of the Alzheimer associations here in Europe, how they approached ACP, and tried to learn from how they wrote down the difficult processes and legal aspects. And after that, we summarized all the information in a preliminary concept, and then we started to develop. So the development was really together with people with dementia and their families, and also healthcare professionals. So we developed a small piece of our website, and after we tested it, consulted, and we adapted based on the feedback, and that went on for 4 times. After that, we didn't receive any new feedback, and then we had our final tool or website, and then we started the evaluation. So I have a small video. So this is the website. You don't have to read the content, but everything you see was really decided by people with dementia and their families how it should look like. So the color, the way the navigation system opened, the content was read by them and adapted. Video was made together with them. There were our interactive tools to start discussing ACP. So this is one of the tools. But also we asked them, what are questions that you want to have answers on? So we added those frequently asked questions on our website with easy to read content. There's also the possibility to enlarge your text, or for some people to change the contrast. So then we started our evaluation study. There was an 8-week study to evaluate the usability, acceptability, feasibility of the website, and also to look at the experiences of the people when they use the websites. And we also looked at preliminary effects on the readiness to start ACP, one's knowledge on ACP, attitudes, perceived barriers, and skills. So very technical. We did it with a pre-post design, mixed methods, and we asked people with dementia, mild to moderate dementia, still living in their own homes, to use the website together with their family caregivers, and we just said, use it the way you want. So we didn't have any limitations on how often. It was just, use it, do you think would be helpful for you? So then we found that people found the website very usable, acceptable, and feasible. We had some positive effects on the knowledge. People felt they could start a conversation about ACP. They also had the feeling that some barriers they had, for example, one of the barriers was that the family caregiver found it hard to introduce the topic of advanced care planning with the person with dementia, and that barrier lowered by using the website. We also found still positive attitudes and an improvement of skills. However, we did see that it was mostly the family caregiver that used the website. So they started using it, and then after they introduced it to the person with dementia, and only a few people with dementia were really using the website by themselves and later with the family caregiver. And especially by those family caregivers that were living together with the person with moderate dementia, they said that early implementation of such a technology is very important, because if they would have received this website 2 years earlier, then they would have properly used it, the person with dementia by himself. So we also looked at how people navigated the websites. So we saw in our systematic review that most tools that exist now to support advanced care planning start with information. If you have read all the information, you can go to your reflection, then you can go to communication, then you can go to documentation. And to us, people with dementia and their families said, we have different levels of readiness. My partner, for example, has a background in nursing, or is a physician. He knows a lot, or she knows a lot about ACP. So we just want to start communicating. So we looked at the user engagement. We did it by how people use the website, so you can collect data, which pages people were looking at, which videos people were looking and viewing. And we saw that there was a low, moderate, and high engagement. And you can also see that in how people navigated. So there was a person with low engagement, so you see that they really go from one page to the other. While you see where people with a little bit more engagement, a moderate engagement, they hop a little bit back and forth to different pages, but still quite a direct path they're going through. Then people with a high engagement, they go really back and forth to the different pages. So they read some information, then they go to the pages that stimulate communication, go back to the information pages, and so forth. So in conclusion, we see that such a website for people with dementia, at least the way we developed this, is very intuitive to use and easy to use, and it could support ACP in the family context. However, it's very important to use such a nonlinear approach so that people use a tool the way they want and the way they need. And it is really to empower and to inform, but we should not forget that it's complementary to the advanced care planning, what you do with your healthcare professional. Thank you.
Thank you very much for this quite clear and informative presentation. Are there any questions, please? Yes, please, Kevin. Kevin is from Ireland.
Thank you. Great to see you. Great to see you give a presentation. Do you have any particular reason why it was mostly caregivers, used by caregivers, and not by people with dementia? I'm just wondering, was there an age barrier? Was age the determining factor in that?
So I think there were multiple reasons. So we did have some dropout in our study. So people that were initially willing to participate in advanced care planning, and then they decided that they didn't want to do it anymore. So that, I think, would be one of the reasons. And we do see in research that it's very often the person, the family caregiver, that is very interested in advanced care planning, and that the person with dementia just wants to live in the now and not think about the future. So that could be possibilities, but we didn't really look into the data because our data that we did the navigation was we couldn't match it directly to the person with dementia. So that's something to look into, but yeah.
Yeah, thanks so much, because I'm involved with different companies that are developing apps, and they find that the person with dementia, that they get more information out of them than they can out of the caregiver, if that makes sense. Once the app is linked to the caregiver as well.
Yeah, for example, in apps that support reminiscence, you see that the person with dementia uses it more. But we did expect this result because advanced care planning is often asked for by the family caregiver, because there's a tendency of living in the now and not thinking about the future for some people with dementia.
Thanks very much.
Thank you.
Thank you. Thank you for your question, Kevin. Thank you for the answers. Are there any other? Before you mention any, I would like to ask you about the connecting with other websites, because there are some websites and it is sometimes very difficult for people with dementia, their caregivers, to get orientation in this network. So do you think that, do you plan to connect with other websites so it will be easy for people with dementia to find this web?
This website in particular, yes. So from early onwards, we knew that we didn't want to keep this within the university, and we also asked participants, barriers and facilitators to finding the website, and together with the main dementia organizations in Belgium or in Flanders, the Alzheimer Liga Vlaanderen and Expertisecentrum Flanders, we will hand over the website so that it's really easy for people to find, and we will work together on the dissemination. Yeah.
Thank you. But you are a communication specialist, so it was an odd question. So thank you very much.
So much.
Thank you. And our last but not least, of course, speaker is Thanos Chatzikostopoulos. I don't know, Thanos, if I'm better in pronunciation of your surname already, from Greece. He is a PhD candidate in psychology from the University of Thessaloniki, and he will speak about effects of palliative care on people with late-stage dementia, about the person-centered approach. So the floor is yours. Thank you.
Hi, everyone. Thank you for this opportunity to speak about our efforts in our unit of palliative care for late stages dementia that we have in Thessaloniki of Greece. So this is the outline of my presentation. And at first, I will start with palliative care. What does the palliative care? Manages patients' symptoms and improves their quality of life through services including nutritional guidelines, pain management, and family and patient support. The goal of palliative care is to improve the quality of life. That can improve some symptoms, prevent symptoms using suitable and personalized medication, prevent symptoms caused by extra medication, and reduce the physical and the psychological burden of the caregivers. But palliative care in late stages dementia is a little bit different, because here we have challenges in communication. The people can't communicate. Most of them have lost their ability in speech. And we focus on comfort rather than cure. Also, we have to face the extensive cognitive and functional decline, the grief of the family. And for this reason, we have to have a person-centered approach. We also perform regular assessment and care planning, and we have an interdisciplinary team with social worker, psychologist, neurologist, general doctor, nurses, and some volunteers. We want to offer a holistic care, and these are the 5 domains of holistic care: spiritual care, cultural care, emotional and social care, and physical care. Our unit of palliative care is located in Thessaloniki of Greece and has 25 patients with dementia in late stage. The goal is to provide high quality care in order to increase the quality of life and create a familiar place that looks like home. So we have a daily nursing routine which involve taking vital signs, daily hygiene care with oral hygiene, full body and skin hydration, daily local cleanliness for the prevention of bed sores, and the feeding that with Mediterranean diet only, and with standard meals, breakfast, lunch, and dinner, and the hydration of our residents 2 to 2.5 liters per day. In the lunch, our people eat all together, as you can see, and our purpose is to focus on the needs of these people, to understand them, to understand what they want, and to offer, to fulfill their wishes. This is difficult, but we are there to try to understand them with every way that can communicate, or through EEG and other processes. We also have physiotherapy sessions. We try to mobilize the patients every day and to have group activities for their communication, to improve as we can their communication. Reminiscence therapy is also a very important part of our work, to use memories to enhance the psychological well-being. We use different prompts every time, and we have to adapt and individualize every program of reminiscence therapy to the specific needs of the residents. The benefits is the improvement of mood, decrease of agitation, enhancement of overall well-being, memory preservation, and validation and sense of self. Here you watch people to watch a football game. Also here they are going to, in this framework, they go to the church all together, or in the other image you see, this is a traditional custom in Greece at the Eastern, where the people picking up red eggs. We also use snoozelen. Snoozelen is a therapeutic approach that provides controlled and stimulating environment to engage and interact with various sensory stimuli. The aim is to engage and stimulate all the senses, the sight, the hearing, touch, smell, and taste. And the benefits are that offers a non-threatening and enjoyable sensory experience, relaxation, and reduction of anxiety and agitation. The present study has the aim to examine the effects of the offered palliative care on cognition and behavior of the resident after 6 months of operation. It was 19 participants with late-stage dementia who live in our palliative care unit, and an extensive neuropsychological assessment was used with all these measures that you can see. For the results, we used ANOVA, and we saw statistically significant results in neuropsychiatric inventory, quality of life in Alzheimer's disease, and severe impairment rating scale. At first, in neuropsychiatric symptoms, you can see the changes in the score of neuropsychiatric inventory. As you can see, there is a reverse scoring here. So you see that at the baseline they have a big score, indicating that they had severe neuropsychiatric symptoms, but after 6 months you see that the score is statistically significant lower. And the quality of life, which is a very important aspect, and our goal to provide the best possible quality of life. You see that it is improved from the baseline through until 6 months that we measured again. But something that it was very interesting, it was a change and improvement in some cognitive functions, and specific in memory, language, and motor, measured by severe impairment rating scale. Here is normal scoring, so you see that in baseline the score was 9.7, the mean score, and after 6 months the score was 2.8 in this scale. Again, the results was statistically significant. And some general stats after 1 year of operation that I have included. We had 28 people with late-stage dementia in our palliative care unit. We had, unfortunately, 7 deaths and 21 transports to hospitals due to some health issues. Almost 57% due to urinary tract infections, almost 28% due to respiratory infections, and almost 14% due to other causes. We also had 6 people with COVID-19, but fortunately no one had something something significant symptoms. And at the discussion, we had a significant involved variable, the transports to hospital due to infections, because when someone leaves his place, because this place is their home, when they leave this place, then they lose their orientations. This affects them significantly. The limitation is that we had a small sample, and we didn't have a control group. However, our intention is to compare them, these people, with people that are visited by our home care unit to see the differences in the care. And the conclusion is that palliative care can offer not only emotional well-being, but also improvement of cognitive functions, even in late stages dementia. Thank you.
Thank you very much for your presentation. I'm sure there will be any questions. Are there, please? Yes, please, Raymond.
Well, thank you for your interesting presentation. I wonder, what's exactly the reason that these patients are transferred to hospitals because of urinary tract infection and pneumonia? Because one would expect, at least in the Netherlands, that these people in late-stage dementia would have maybe do not hospitalize advanced care planning agreements, or that there is a doctor on site that would be able to treat urinary tract infections and pneumonia. So maybe it's a cultural difference, but...
it was also my question.
I'm curious to know.
Yeah, so many of them has microbes that are in their organisms already. So they are activated or deactivated from time to time. Okay, and we don't have all the antibiotics to heal them. So, because in Greece, I don't know, in Netherlands, I'm sure that it is better. But in Greece, some antibiotics we can't find them in pharmacies. There are only in hospitals. And especially for urinary tract infections that are very difficult to face.
But is there a doctor on site there?
Yeah,
oh,
there's a doctor, and she calls the if she judges that there is any other solution, and we can't, because at first we try with the antibiotics that we have to solve the problem. But if it is serious and we can't face it, we have to send them to the hospital.
Thank you. Thank you very much for this explanation. Another question there, please. If you can kindly introduce briefly yourself.
Okay, thank you very much. How many doctors and nurses or personnel working in your center?
How many personnel?
How many doctors, technical personnel, nurses working in your center? If you know.
Yeah, we have one neurologist. We have one general doctor, 12 nurses, one psychologist, me, a social worker, and two people about the general things that we have need. Yeah. This is the personnel.
For 25 patients?
Yep.
Yes. Okay, thank you.
Also, we have some volunteers to help us with the work, especially in the evenings. And we have psychologists and other and physiotherapists that come for their practice in their universities. They came for their practice to our unit.
Thank you very much. Thank you for the question and the answer. Another question, please. I just wondered about your improvement of cognitive functions, and I would like just comment that it is not the cognition due to dementia, but due to delirium. But I would not, I know that you are a psychologist, so I do not want to trouble you. I think maybe it is another question that you would ask, the same as I wanted to ask about urinary infection. But yes, it is what we understand. Patients are also improving when coming from hospital after delirium, and also their cognitive status is improving. But unfortunately, we still cannot cure, improve dementia. That's it. So another question, comments? Yeah, Raymond. I would introduce you, Professor Raymond Koopmans, a professor of primary care medicine in the Netherlands.
Thank you for the introduction, Eva. Did you call it late stage dementia? Any definition about that? What
okay.
Is there any threshold or any assessment scale that you say, okay, now it's late stage dementia?
Late stage dementia in general is the inability to walk, inability to stand, inability to talk, but there is an objective measurement, the global deterioration scale. The global deterioration scale has to be 7 in order to be accepted in our unit. And also there is another measurement, the FAST scale, that also can separate the stages of dementia even more precisely.
Yeah, thank you. Okay, that's a clear answer. It's a clear definition of the late stages, indeed.
So, thank you very much. I do not see anybody. Looking at the clock, I think we are pretty on time. So I would like to thank you very much for your kind attention, for your discussion, and especially to our speakers for their fantastic presentation. Thank you very much.